in external rotation, the foot's going to go inward. Okay? I'm going to stabilize here. It's hard for me to stabilize and palpate where the muscles are actually working. So for this, we're actually just trying to control or minimize, well, we're allowing femoral rotation, but we're not letting her bring her femur up towards the ceiling or anything like that. And we're trying to watch to make sure her pelvis stays level. Okay, so we're going to block the femur, and then we're going to apply the resistance this way. So, Aki, go ahead and bring your foot in. Good. So she's at least a 3. I'm going to hold here. Okay. I'm going to try to bring your leg out of that position. I want you to hold it right there. Okay. So basically, what I'm doing is I'm stabilizing the femur. I'm just above the ankle. Okay. Just proximal to the ankle, and I'm not just applying straight towards me because this is a rotation. I'm applying almost like a little bit of a scooping movement. Okay. Hold it right there. Hold it right there. Hold it down here. Hold it, and up. A little cheating, but not bad. So, keep in mind, this ties in back into what you were saying. These muscles are much smaller. So I'm not going to apply nearly as much pressure as I would for, say, the quads, as I would for the hip external, internal rotators. Much smaller. Less cross-sectional area. You don't need as much force. Go ahead.
I'm always afraid that I'm going to hurt somebody, so I never pull hard enough. How do you, get over that? Did you have a problem?
Well, you know
with
what's
that?
amazing about manual muscle testing is, by definition, you're supposed to do it 3 times. So you have one chance to apply some pressure, see how they do, reassess, and then at that point you can either determine that was enough for them, or I can either turn it up to see what they can maximally do with their strength. That's what's nice.
Okay.
So we don't usually have you do 3 times, but that's one way for you to kind of gauge and assess and reassess. Okay, same thing here. Go ahead and bring your foot out to rotate through here. Go ahead and bring your foot out. Yep, that's pretty good. Try to relax your feet, your toes, and all that. Just bring it out. Stabilize here. I'm going to come just proximal to the ankle. Hold it right there. Hold it right there. Hold it right there, and relax. Okay. Again, it's hard for a lot of people. I'd be surprised if too many people were 5 out of 5s on maximal resistance for that. Because most of the things that we do are in the sagittal plane. We work a lot of our big muscle groups. A lot of us, unless we intentionally train it, we have weakness in the transverse plane of our hip. That was one of your questions in the SPTA critical thinking for this week about marathon runners. A lot of times they wonder why we train them in the frontal and transverse plane because their sport is here. Well, a lot of those stabilizing muscles get tired, their form gets sloppy, and then they have to work harder, and they end up performing poorer. So check that one out if you haven't yet. It'll make you think a little bit about that. Okay, so we talked about hip flexion, MMT. We talked about internal and external rotation. You position the muscle in the shortened position, and then you try to pull the patient out. It is a little bit more of a scooping effect rather than just a straight line of pull. You stabilize the femur mostly to prevent hip flexion, and you still want to allow some rotation to occur at the femur because that's how the muscle activates. Let's do the range of motion now. And we'll practice. Go ahead and slide that under one of your legs, whatever you prefer. Alright, so for hip, internal, external range of motion, where's our axis going to be? Midpoint of the patella. So I need to position myself to measure to eye level, right? Okay, so that's pretty close. Not bad. Okay, midpoint of the patella. Stationary arm is aligned with, it's basically perpendicular to the floor, right? And then the moving arm is aligned with the tibial crest. Okay, so you might have to say to the patient, I'm going to touch your leg. Sorry if my hands are really cold. Okay? And I raise this as high as I possibly could. And what's normal range of motion for both internal and external? It is, the landmarks are the same, the range of motion is the same.
45.
Okay? Clinically, I think you'll find, as is the case with me, a lot of us cross our legs, so we have a lot more external rotation than internal because we don't do a lot of stuff like this. You know, it's not really functional. So you'll see a lot more people who have increased external. So my balance, my arc of motion is still there, but it's kind of out of sync because I have more external and the
So
internal.
it's 45 for both?
45 for both. So there should be an arc of how many degrees? 90. So I have the 90, but I have a lot more external than internal. So I'm a little off balance. Okay. So again, axis, midpoint of patella, stationary arm stays perpendicular to the floor, and the moving arm is aligned with the tibial crest. Okay, Mackie, what I want you to do is I want you to keep, and there's a towel roll underneath to keep the femur basically parallel to the floor. So basically to keep it in better alignment for more accurate measurement. What I want you to do, when I say so, I want you to bring your foot towards your other leg as much as you comfortably can. Keep this, keep your leg down in contact with the towel, don't lift it up. Keep your pelvis level, and try not to move your body side to side. Sit up nice and tall for me, okay? When you're ready, go ahead and bring your foot in for me. Bring it in, okay? Is that as far as you can go without cheating? And relax, good, relax. Now go ahead and bring it out for me the other way. Is that as far as you can go? And relax. So she had about 40 of internal and about 32 of external. Okay, so she's a little short. We can give her some stretches, no problem.